start off?
Yeah, fire.
Okay. Well, good afternoon and welcome to this august setting. What a beautiful spot. I guess it's appropriate that we're considering the future of Medicare in a room that looks like it's been around for several hundred years. And I just wanted to, that's the last thing I'm going to say about Medicare in my introduction. James Madison famously said that no man is allowed to be a judge in his own cause. And since I'm actually, as part of this scrum, I'm not going to advance any of my comments except to say that they're going to be very well considered and thoughtful, and you should really like them. So I want to thank Zach Cooper, who is a professor in the School of Public Health and economist, because he's really the one who set this up. And he was able to set it up because of the amazing staff that we have at the Institution for Social and Policy Studies. And Pam LaMonica, Pam Green, Lori Hirschman, Tori Bilski, these amazing staff members were what really made this event possible. And I would only say one other thing is that I guess I'm on your left, that having set this up, Zach managed to position the panel so that I would be the most liberal commentator, which is a position I don't always find myself in. There actually are people quite a lot of people who criticize me for not, for example, during the last healthcare reform debate, calling for single-payer national health insurance. So this time, I guess I'm gonna play the type and be a stalwart defender of Medicare in ways that I'll discuss. Oh, I've already broken my rule twice. So I'm going to leave Sarah to do the intro, but I really want to thank everyone for participating in this, and I just want to say a few words about the Institution for Social and Policy Studies. It is as old as Medicare. Well, not quite. It was created in 1968. Medicare was at 65, of course. And when it was created, it was in this burst of enthusiasm for the social sciences. In fact, I think the president of Yale at the time said that it would bring an explosion of the social sciences to bear on pressing real-world problems, which doesn't, I don't know, sound all that exciting to those in the social sciences if they're exploding, but it turned out that there wasn't a major advances that occurred in the social sciences at that time and in later years, and I think it's very heartening to have this enthusiasm about what the social sciences can do to illuminate the kinds of issues we grapple with every day, and that's really what ISPS is seeking to do. I've been head of the institution since July 2011, and in that time I've really focused around three pillars: advancing the high-level social science research that we do in political science, sociology, economics, psychology, and then trying to do more to actually bring that research to bear on important domestic policy questions. And one aspect of our work that I really want to emphasize is that we're also trying to develop the next generation of leaders in public policy and public policy research. And we have a number of programs underway that engage graduate students and undergraduates, and the events like these that are to bring together a broad cross-section of the university community really express that larger mission. The last thing I'll say is that with Zach at the helm, I'm launching a healthcare initiative at ISPS, which will include him and this amazing group of health policy scholars that Yale has developed over the last 10 years or so, including Abby Gluck in the law school, Amanda Kowalski in economics, Jody Sindelar at the School of Public Health, Fiona Scott Morton at the School of Management, Betsy Bradley, who is starting a new global health program, Harlan Krumholtz at the medical school. I could go on, but the point is we have a lot of the top health policy experts in the country, indeed in the world, and we're trying to bring them under ISPS's umbrella to really think together and work to try to develop effective research and strong policy ideas. All of which is to say, I really hope that if you're interested in these topics, you get involved with ISPS. Our website, isps.yale.edu, just redesigned, is a really good portal for all of the work we're doing. So thank you, and thanks for coming for this event.
Oh, great. Well, thank you everyone for being here. My name is Sarah Cliff. I'm a health policy reporter at the Washington Post, and very excited to be here with this great group of people to talk about one of my favorite subjects, Medicare, which, as a health policy reporter, right now it's a really exciting time to be looking at this program. Definitely a challenging time, but one when we're talking about a lot of different ways, this program is going to develop, and there could be very big changes on the horizon. So I'd love to start, let my panelists introduce themselves a little bit. And I guess I'd also love to hear everyone's thoughts as we're getting started on this discussion of what you see as the main challenge on Medicare. Is it spending? Is it structure of the program? But kind of what is the big challenge when you think about Medicare policy? I guess I'll start with you, Zach.
Sure. So thanks, and thanks everyone for coming. So I guess the question for me is, do we have a Medicare problem or a healthcare spending problem? One of the things we've seen for the last 45 years is that healthcare spending is growing faster than the rest of the economy. And the byproduct of that is that the Medicare program is becoming much more expensive. The reason I think Medicare is such an issue today is we cover 50 million elderly Americans right now. If we look out in 40 years, that number is going up to about 90 million. And so you got more people who are going to need to be covered. You got prices or the cost of introducing Medicare going up. And then by virtue of this aging, you've got a smaller base who's going to pay for it. And the question is, where do we want our investments to go? Okay, do we want a larger share of government spending? Right now it's a sixth of what the government spends, projected to go up to a quarter. Do we want that to be the case? Do we want all the money going to this single program that's going to occupy a larger share over time, or do we want to see it start transitioning to make the investments that we probably need to make in infrastructure and early childhood education and in research? And the question I think fundamentally is how do we do that? And I think our politics right now, if you ask voters what they want access to, basically they want everything, and they don't want to pay for anybody else to have it. And so I think our politicians are responding to it. And so the question is, how do we introduce the types of changes, either through a private route or probably distancing Medicare from the day-to-day sort of machinery of government, that allows us to make the types of changes we need to make this program sustainable?
Okay, I'm David Brooks from the New York Times. I should say that when I was invited to this, I was promised I would be taking part in a roundtable discussion. And I thought that I could hide my ignorance. I was only given a semicircle, and so I'm a little more exposed than I hope to be. But I know the least about the policy of anybody up here. So my interests are in the politics of it and in making sure we have less of it. And so, I've read a zillion different versions of the following statistic, that the average Medicare recipient couple pays, you read vastly different numbers, but the ratios are usually similar. They may pay $145,000 over the course of their career into the system and take out $345,000. That's sort of one ratio. I've heard of many different versions. But the basic truth, I think, seems to be people pay a lot less than they take out, and that's basically unsustainable. And so my entire interest in the Medicare issue is how do we get less of it? And so entitlements used to be a small share of income of the federal government. Now they're a medium share or medium large. By 2022, I think they'll basically consume all of total federal revenue. And so that's simply unsustainable. And the effect, which is not future, but which is current, is the squeeze on entitlement programs, on discretionary programs. And so Barack Obama attacked Paul Ryan, rightly I think, for having an unconscionably low level of discretionary spending. So historically, discretionary spending has covered around 3 or 4% of GDP, and domestic discretionary is all this stuff, education, welfare, infrastructure. It's usually been about 3 or 4, and Obama noted in the Ryan budget, it gets down to about 1.7% of GDP, which I think is unsustainably low. If you go to the president's budget in the OMB numbers, his budget gets down within 7 years to 1.8% of GDP. So the Obama budget is the Ryan budget. And you have to do that because of the way Medicare is expanding and eating up everything else. So to me, the government has become a giant machine for taking money from struggling young families and giving it to affluent elderly people. And I basically want to turn that around. And I don't really care how. If it's single payer would do it, or a big part of a big single payer system, basically I'd accept that. I basically buy the deal that you can't that the fundamental problem is in the incentives at the base, at the fee-for-service system incentives, and so somehow we have to look and change those incentives. And so that's my basic interest, and for anybody who's a current recipient of Medicare, I think if you're above a certain income level, you should pay less, pay more and get less. And if you don't like it, I'm going to try to outrun you.
We have an exit right over there.
So I could quit there and say I agree with David on everything. I'm supposed to get more into the weeds, I guess. So anyway, I'm Tom Scully, and I'm a partner at a private equity firm in New York. But my role here, I was President Bush 41's healthcare staffer in the White House for 4 years and did most of the stuff for George Bush 1. And then I came back for George Bush 43 and ran what was then called HCFA, and I changed the name to CMS when I was there the first week. And so I ran CMS for about 3.5 years. My primary job there was designing and pushing through Medicare Part D, which was very controversial at the time. And one thing I would note is I think David's right about the politics. At the time, I was a horrible, rotten, lying, horrible person for pushing through Medicare Part D, and now it's not controversial at all. So one of the worst things about the healthcare politics is that, I didn't support everything President Obama did. I probably would have spent a lot less, but the structure of the Obama plan is virtually identical to the structure of the George Bush 1 plan that I wrote in 1992 with Dick Darman, who you may have known, who's since passed away. Structurally, it's the same thing. So what President Obama was trying to do is right, whether you should do it at the time of a 10% of GDP deficit, and whether you should do it with the massive amount of spending we're taking on in one day next January 1st is another issue. But my point is, it's like Pavlov's bell. The Democratic administration proposes something, and a Republican beats the hell out of them and says they're wrong without looking at the substance. And on Part D, I can promise you, if you go back and look at it, every Democrat beat us up because it was George Bush's idea, so it must be terrible. Now, it's very hard to find a Democrat that doesn't like Medicare Part D, and the program's a huge success. So sadly, the politics rarely has anything to do with the substance, which is unfortunate. But I think what the real issue comes down with Medicare is private versus public. So if you really look at it, I personally believe, I love Medicare, it's a great program. Why do seniors love it? It's a $12,000 benefit on average that a senior pays $1,200 for. So what's not to love a 90% subsidized benefit, especially if you're rich and you're living in Naples, Florida, playing golf. And fundamentally, the issue is how do you deliver services appropriately? And if you look at the models that I think work, the Federal Employee Health Benefits Plan, I was a federal employee for 16 years. 8 million federal employees get their plans, get their health care by buying it through a very competitive, well-regulated set of private plans, the Federal Employee Health Benefits Plan that every federal employee loves. Medicare Part D is a totally private, negotiated system run by private contractors. The government's not involved at all. It's worked pretty well. The fundamental problem with Medicare is it's single payer. If you like single payer, the government, and I love it, my old staff, fixes prices. Every doctor in New Haven, every hospital in New Haven gets paid the same thing. In the history of mankind, in the history of every economy in the world, price fixing has never worked. If you fix prices and you pay every doctor and every hospital the same thing, what do you get? Volume explosions. I mean, it's, 1 + 1 = 2. And the fundamental problem with Medicare is the government fixes prices. So fundamentally, if you want to make the system work better at some point, which I believe, you need to get to the point where you have people buying well-regulated private Blue Cross or Aetna or United Healthcare plans instead of having the government fix prices. The government doesn't fix prices for food, and it doesn't fix prices for public housing, the other two things the government needs to provide. And the economics, the problem with Medicare is the government has a single payer, and it's a wonderful program, but a behavioral disaster. So when I went into CMS in 2001, we had 3% of people in private health plans, and now it's 28.5%. Almost nobody's noticed that, but 28.5% of seniors this year will be in a private health plan. They get better services, they get more coverage at lower costs, and well-regulated competition works. So I think Part D is an example of that. The Federal Employee Health Benefits System is an example of that. And I think part of Medicare Advantage, when well run, is an example of that. So when you really look at the fundamental problem with Medicare, Medicare is a critical program. It's not going to go away. You want to make it work better, you have to at least have some semblance of price and quality competition. And I think that's really the key issue that too many people talk past.
Well, I guess having set this up this way, Zach, you're going to make me play to type because I think it's really important to start with two critical points. One is the enormous value of Medicare as a program. And one way to understand that is to think about why the healthcare market is not like the market for food or housing, why it is that before Medicare existed, it was so hard for seniors to get affordable health insurance. And the primary reason is, as most of you probably know, is that a very small portion of people account for most costs. So, and we're not talking here about doing away with Medicare, we're talking about having this set of options that is being discussed is about having a basic commitment, but having some kind of competitive mechanism among plans. But I just want to remind people that the reason why Medicare exists at all is that there are fundamental problems in the healthcare market that Medicare was there to address, namely that it was almost impossible for seniors to get affordable health insurance before the program existed, and especially as plans got more and more sophisticated, and they're certainly sophisticated now at trying to weed out high-cost patients. Now, a couple quick points. One is that Medicare's costs right now are growing more slowly than any other part of the health system, and that's not a new development. Its costs have been growing more slowly than private health insurance costs by roughly a point a year since the 1970s. There's a larger difference in recent years. Right now, we're talking about Medicare cost growth is essentially zero. And that, while it's hard to know how much that's due to some of the reforms that are being pursued within Medicare, I think it's worth noting that this is not a new development. This general system-wide control of costs that we're seeing right now, or at least slowdown in costs, is even more accelerated within Medicare. The second thing I would say is, and I think this is very important to understand, is that the private plans within Medicare, which I support, and I've argued for a similar system for the non-elderly population, that is a system where there are private plans but also a public option. The Medicare public option, if you will, competing with private plans, has consistently lost money because of the private plans. And the reason being that they have selected healthier patients, and the reason being as well because there's been actual subsidies for the plans that are thankfully being ratcheted down, although partially offset by some quality incentive payments. The last point I would want to make here is that if the concern is about Medicare becoming smaller, that is a very strong argument, as Zach was suggesting at the outset in his question, for much more aggressive attempts to control costs, both within Medicare and beyond. And I am a healthcare deficit hawk, if you will. I've called for an enforceable budget for Medicare spending. I believe that the mechanisms that Medicare uses to control costs, as Steve Brill in this very informative Time magazine article talks about, where Medicare is paying much less for individual services and individual goods than our private insurance plans, that there should be a move to try to do that kind of serious efforts to control costs at a broader level than just individual fees and prices. But my point would be that, and I believe in the Independent Payment Advisory Board, which is basically independent in substantial respects from political control with a mandate to control costs. So one can be strongly supportive of reducing Medicare's size while not believing that the right solution is to shift more costs onto seniors or to rely more on private plans. And one factor that we should keep in mind when we talk about very wealthy Medicare beneficiaries is that in 2012, and I won't try to show you this figure, I will try to, but you won't be able to see it, 5% of Medicare beneficiaries had incomes above $88,000 a year, 50% had incomes below $22,000 a year, 25% had incomes below $14,000 a year. It is a wonderful thing that the elderly are no longer the most disadvantaged segment of our society, but we shouldn't pretend that that we're talking that the bulk of Medicare spending is going to really affluent people.
Great.
I think the question is what's the...
You guys have to have lunch every day, by the way?
Yeah, exactly. The question is what's the precedent for the private sector? And if we look outside of Medicare, it really is the prices that are rising for private insurers, the price that hospitals are charging that are driving up healthcare spending. So if we look outside the elderly population, it's precisely the sort of consolidation in the hospital industry and the weakening of these private insurers that's failing to take prices down. I think the second issue is if we look at who introduced regulated prices, it wasn't Democrats. It was Ronald Reagan, introduced the price fixing. And I think the challenge is there's just not a whole lot of evidence. Jacob talked about the Medicare Advantage program. I think Part D, the other challenge with it is pharmaceutical spending. So part of what happens with Medicare Part D, it's come in under budget, and that's been one of the largest arguments made for it. It came in under budget essentially because pharmaceutical spending slowed down in the 2000s.
Why do you think it slowed down? You think it was magic?
No, but it slowed down for those
I can
under
tell you why it slowed
65 as
down.
well.
It
No, but
slowed down for one reason. It was in the reality, which drives me crazy. The Democrats want to close the donut hole, which may be the dumbest policy in the history of the world. I spent years designing the thing. Okay, the donut hole is there are 15 million seniors that have no co-payments and no deductibles, poor people. As you go up in the income stream, you have low-income subsidy people. There are another 7 or 8 million that have significant subsidies. The reason the spending has dropped is because there's a significant cost share and seniors are smart. And on January 2nd, when they realize that they're not rich, they're going to hit the donut hole, they switched to generics.
But then why is-
Generics went
why
from
is spending under
45% to 80%.
But
The switch to generics was all of it, and it was designed to be that way. And so when you go out and tell us, not a non-poor senior, by the way, we're going to close the donut hole by collecting taxes from the guy digging ditches out front to subsidize your drugs, they're going to say, well, maybe I'll just keep taking Lipitor or else is on patent instead of switching to a generic.
No,
The
part of it is
cost,
that
the
new
reason it
drugs
came
didn't
into
come to
price
market.
was 100% the donut hole, and the reason it was designed that way was to drive non-poor seniors into making rational choices to get away from name brand drugs and go to generics. It wasn't by accident.
But you wouldn't expect then the share under 65 to mirror the share over 65. So if Medicare was somehow doing something totally differently, the rate of spending growth on pharmaceutical care
Yeah.
for those in under 65 and those over 65 would look very, very different. And what they look is almost identical. And some of that's because more drugs were going on to generic,
Yeah.
which explains a lot of the increase in generic prescribing.
Some of it was a
The other is
wake-up
there wasn't
call if you look at how the PBM business works.
This is what the trustees say. The reduced estimates reflect the higher market penetration of generic drugs and a decline in the number of new drug products that are expected to reach the market during this period. And it should be noted that that private drug spending came in 35% under expectations, whereas Medicare was 41% under projections. But the difference is because fewer than expected people signed up.
Well, yeah, I would note, I was a trustee for years, and I would note that the chief actuary wrote that report, estimated the Part D to be twice what it costs today, and he was totally wrong. I had many public fights with him. He was wrong. I love him, he's a great guy, but he was fundamentally wrong. Behaviorally, what's driven the change is the change to generics, and also the fact that the PBM business, which is how people buy pharmaceuticals, Caremark and Medco and those folks, used to be a pass-through business most businesses didn't understand. One of the things that happened with Part D is most large employers started realizing, wow, these guys don't care about our costs. They're worried about rebates from drug companies, and it changed the behavior.
I mean, so I'm super sympathetic to competition. Most of my research is on the effect of competition on raising prices. So consolidation increases price. The challenge is if we look globally, there's just no precedent for it. The prices in the U.S. are vastly higher than they are in any other country. We're also the only ones who allow price competition for everything. I mean, it's higher for drugs, it's higher
How
for
much price
hip
competition
replacements.
is there when you look at the market you talk, and I agree with you, by the way, antitrust enforcement is probably the most
It's the single
important
most
thing you
important thing we can do.
Consolidation of hospitals, which is a disgrace around the country, consolidation of insurance plans is a significant problem. In a healthy market, the doctors, the hospital insurance companies should all have relative balance of power and not like each other very much. That's a good thing. And there's way too much of that going on. But when you look at competition in the marketplace, for Medicare, 18% of the people in the country are seniors, 50% of the consumption, and the government fixes prices. Another 25% is Medicaid. So when you say we allow price competition, it's kick the ball and drag the government. The vast bulk of the market is price fixed by the federal government. You go out in a major market where you have huge insurance consolidation, and the biggest insurance carrier will have 7, 8, 9% of the market, a really strong Blue Cross plan. Why? Because the government dominates the market, and the insurers are minor players.
Well, if you look at, say, C-sections, which most Medicare beneficiaries aren't having, the average price for a C-section in the next most expensive nation is Australia, where it is $10,000. It's $15,000 in the United States. It is, and let's just throw in a couple, France, $6,000, New Zealand, $4,700, Switzerland, which is a country that has a system that is, it's similar in some respects to what the Affordable Care Act is seeking to achieve, is around $5,000. So, I mean, we are, someone summed it up. I think there's a lot going on, but the price levels in the U.S. are much higher than in other countries.
And I'll bet
Go
you if you
ahead,
look at this chart, they've gotten a lot worse since 1965. And what's-
This is just the
Yeah.
2012.
And the reason since 1965 is, God bless the Medicare program, if you get in the mechanics of the Medicare program, you go to any teaching hospital in the country, and I used to run a big hospital association, you go to the poorest town in the country, they got a brand new hospital with 2 new wings. And what's it built with? Medicare money. Because every one of them gets massive subsidies from Medicare, IME, GME, disproportionate share payments.
I mean, so
I haven't looked at
argument
the
you're
Yale
making is-
hospital, but I can tell you, I'm on the board of the Dartmouth Medical Center, I love it. We got a brand new hospital, we're building new wings every week.
I mean, so
Every
it's-
hospital in the country is, it's Medicare money.
So the way I started was saying, do we have a Medicare problem or a healthcare problem? And
Both.
your argument is that the Medicare problem is what's exacerbating the healthcare problem.
It's created the Medicare problem has created the
Created the
healthcare behavioral problem, and it's making it worse, and it's very, very, very political, and it's not going to get better without people understanding the mechanics and the details.
Do we have agreement, maybe for Jacob, on the basic, the donut hole skin in the game, if I can combine 2 ugly metaphors, that the consumer consciousness on the part of the recipients is a key part of the solution? Do you agree with that, Jacob?
I agree with it insofar as there should be cost sharing, particularly there should be cost sharing, and there is quite a lot of cost sharing already in Medicare. In fact, one thing I would say, and I think we might all agree on this, the unification of Part A and Part B and creating some catastrophic coverage would be a really important reform that left and right should agree on. However, I will note, and this comes out of the work of Jonathan Gruber, that that cost sharing is not particularly effective for the highest cost cases, and those often also involve, and so what you want to be careful with cost sharing is basically a tax on the sick. And that is a real fear, particularly with sort of so-called consumer-directed health plans. Since healthier people tend to select into them, that's not been a big problem, but were that to be more the norm.
Well,
If you went back to the RAND, really quickly, if you go to the RAND health insurance experiment of the 1970s, which is sort of considered the gold standard for thinking about cost sharing, they found two things, right? They found that cost sharing seemed to be pretty effective, particularly in reducing hospital care, but it was not very, the individuals were not very good at distinguishing between necessary and unnecessary care. And it wasn't a long enough experiment to know what the real health effects would be. So cost sharing, it strikes me, it can be an important component, but to think that that's going to really be what's going to create substantial, sustained reduction in cost over time, especially when 5% of the patients are accounting for, I don't know, half the cost.
So that's the number right there. So
It seems unrealistic to me.
10% of Medicare beneficiaries are responsible for 57% of the spending in the program. I mean, there's a very, very tiny group who are essentially driving costs up. And I think the question is, how do we address the spending of that very, very small portion of the population?
There's a lot of issues there, including hospice care.
Right.
But, you know, when you look at cost sharing, there is no cost sharing.
It's Medigap.
Well, let me ask
Medigap
about.
has
Okay.
garbage insurance. Medigap, most seniors, I bet people in this audience say they don't understand the fact it's not Medicare. They say, well, I have Medicare and it has these ridiculous $1,000, $1,100 deductibles for hospital care and whatever for 116 or 126 for physician care. But do I really pay it? No, I pay Blue Cross of Connecticut $400 a month on top of my Medigap.
So
And
I'd
it's
get rid of
garbage
Medigap.
insurance, and it has 65% medical loss ratios. It has nothing to do with the Medicare program. The people are insulated from the cost share, so they're totally insensitive to it. So when they go to the hospital or go to the doctor, most of them don't care because there is no cost sharing. So the fact that changing the deductibles, if you allow people to buy Medigap,
Doesn't matter.
defeats the purpose. What's
So,
the point?
so Jacob, would you allow us to kick Medigap out the window?
Yes,
Okay.
absolutely.
So we've
But I would
reached
definitely,
consent.
yeah, I would definitely, it would have to be done with not just serious attention to income-related cost sharing, but also condition-related cost sharing. And Gruber has a really nice proposal for this that I would recommend looking at.
So we've combined A and B, and then we've kicked out Medigap.
Yeah. So and the one thing I would note is
You're
that
only 100
in-
senators and 435
in the-
House members short.
I've heard you got some big sway there.
This really would require, because I think people don't understand just quite how high out-of-pocket spending is by the elderly on health care. Now, part of this is long-term care spending, which is not covered by Medicare, even though people believe it is. But part of it is just that Medicare actually has some really strange coverage rules that mean that cost sharing can be very high. So the old 120 hospital days rule, right, which may have made sense in 1965, but doesn't today.
Right.
So, I mean, one thing that IPAB, I think, or an independent organization could be authorized to do in the future would be to think about benefits changes that wouldn't reduce overall benefits, you might say, to use technical terms, the actuarial value of benefits, but could have authority to sort of to change the benefit structures in ways that would reduce, that would make more harmonious the treatment of different services.
What are you comfortable with IPAB? This idea of
Here we go.
technocrats?
How do you feel about IPAB?
No, I mean, because I think it's
Yeah.
a question. Should 15 people be able to make? I think it'd be the most effective thing, but are we comfortable with that?
Right, so, well, I'm a Burkean, so I generally have limited faith that 15 extremely smart people sitting here in Washington will be able to master some large percent of the GDP, and I have double my doubts when I see how Congress structured IPAB, which, as I understand it, has been limited and emasculated, and they didn't want to give away total control for legitimate democratic reasons. And then the third thing I'll say is, I used to believe in I'm now blanking on the name, the Base Closing Commission. I forgot, anyway.
The BRAC Commission.
Right,
Yeah,
yep.
so I used to believe in that solution to all our fiscal problems. Let's just give it to some commission.
Yeah.
And I no longer believe that because this is an elemental feature of our social contract, and you just can't do it in undemocratic means. And if you speak to people who've been around, I had a memorable lunch with Dick Darman, which I'll talk a little about later maybe, but he and others who are in the Senate and have been around a long time, Alice Rivlin, said commissions like this only work when they are a mask for legislators who secretly already want to do something and just need a cover for it. And so when you get legislators rigging a commission, then the commission can work. If you ask a commission to do something legislators are not politically brave or foolish enough to do, it will fall apart.
Yeah.
Well, I agree, and I was one of Dartmouth's deputies. But, you know, the issue is about IPAB. It'll never happen, number one, for political reasons, as David said.
And you'd have to have a
I
definition
have
to
not
join
been,
it.
I've quietly been a supporter for one reason. Senator Rockefeller, whose idea it was, an old friend, and I spent a lot of time passing RBRBS with him back in 1989. And his view as a legislator is, when you're sitting around trying to run the Medicare program from the Ways and Means Committee in the House and the Senate, and you can't make decisions, and you watch 20 years of inaction, you throw up your arms and say, at least I'll give it to a panel of experts who might have the guts to do something. And so from that point of view, I don't disagree with him, and I think from his level of frustration, I think IPAB may be fine if you get to that point. The fundamental issue is, should the government be fixing prices at all? I mean, I would say if you're going to be stuck fixing prices, I'm happy to give it to 15 experts who'll do a better job than Congress, who shouldn't be in micromanaging these things. But fundamentally, should somebody be out there evaluating the relative value of an internist? And, you know, a guy gets out of Yale Med School is 29, or let's say the University of Western Guatemala Med School at 29, and he gets paid the same thing to practice medicine in New Haven as the guy who's the dean of the med school. That doesn't happen anyplace else. So when you're out there having the government set relative values, fundamentally the issue is, should the government be fixing those prices? If you're going to, I guess I'd rather 15 experts do it than a bunch of meatheads in Congress.
I wanted, I've written on this subject a little bit. I wrote a piece for the Post called Who Wants to be a Death Panelist, kind of raising the issue you raised of it's one of probably the most unenviable jobs in Washington to be the one who says, no, you're going to get paid less. I wanted to ask you all, though, about some of the other reforms in the healthcare law, because we often talk about the Affordable Care Act as an insurance expansion. About half of the law is related to changing how Medicare gets paid, and some of the ones that come to mind for me are accountable care organizations, where a healthcare system gets a fixed amount to cover a specific patient, and if they can cover in that budget, that's great. They get to keep some profit. If not, they're essentially on the hook. And I'm curious. Another one that has been getting a lot of attention from hospitals are penalties for readmissions, for preventable readmissions. I think there's actually a New York Times article about this a few days ago, about some hospitals saying it's really hard for us to manage people's care outside the hospital. I'm curious if I'm sure everyone will have thoughts on this, just judging from how this panel has gone so far. But if anyone wants to talk a little bit about the Affordable Care Act and how you see that, whether that's going to help solve our Medicare cost problem, or if it won't make any sort of change.
Well, I'll just say very briefly that I think that we should start with the basic principle that there are two major sources of Medicare cost growth, right, over time. One is that there are more people enrolling in the program, and because Medicare costs have been growing so slowly, and in fact I think it was $140 billion was just shaved off of projected growth because of that, most of the cost growth right now is being driven by increasing enrollment in the program. And I think we should think differently about those two sources of cost increase. To think that we could reduce the actually bring down, say, or stop entirely the growth in per capita spending would be really a mistake. It would, and so when we're thinking about a lot of these plans and proposals on the table, one of the really important questions is, like, what is the achievable rate of growth? And what's interesting is that there's actually a lot of agreement now across the ideological spectrum that you need to have some rate of growth that is, close to the growth of our economy, but slightly higher, right? Whether it's the international average, which was around 0.5% more, whether it's current levels, which is 0.4% more, of per capita and age-adjusted growth because as people get older, they spend more. And I think that's really important because what's going to deliver that kind of growth? If you look at the rest of the world, what has delivered the slower growth that we've seen in the United States is countervailing power on the part of insurance institutions, which are either the state, or sickness funds, which are basically mutual insurance institutions that have state sanction. It's highly regulatory, and it works regardless of what the unit is, because it's very hard to control the cost. The pressure from increasingly consolidated in U.S. private providers is to get higher prices, as the Brill article suggests, is very, very strong, and you need to have that countervailing power. So most of the reforms that are being pursued, I think, through Medicare make sense, as a way of trying out new techniques. But my own view is that ultimately it's going to come from saying we're not going to let Medicare spending grow faster than a certain amount, and we're going to give authorities pretty substantial power to create that kind of countervailing power.
So would you support something like a per capita cap on spending, or?
Yes, I have
Okay.
proposed that. However, I would separate that from ideas. I think it's quite important to separate that from plans that have some kind of fixed voucher for coverage in the either Medicare, traditional Medicare coverage, or private plans for reasons we can go into later. But I think that if there isn't that structural feature, if there isn't the incentives to basically shift costs onto seniors, right, that you have real protections, that cost savings are going to come through actual reduction in cost through a variety of means rather than through more costs being shifted on to seniors, then I would be supportive of it.
Well, you know, we talking past each other on the policy on these things again. So if you look at what President Obama's health plan does, I have a problem with the level of subsidies. I have a problem with adding 20 million new Medicaid beneficiaries on January 1st, another 18 million people in the exchanges, and the speed with which it's happening. But what did President Obama do in the Affordable Care Act? He bought private insurance for all these uninsured Americans with vouchers. Exactly what the Ryan wants to do for Medicare. He said, let's go out and set exchanges up. Let's buy private insurance and let's subsidize people based on their income with a transfer payment through refundable tax credits, exactly the way Medicare, Ryan's Medicare thing would work for the Medicare beneficiaries. And if you look at the best reform plan out there, it can't pass. The best policy out there, and I've been saying this for 10 years, it's Senator Wyden, a liberal Democrat from Oregon, who says, let's get rid of Medicaid, let's get rid of Medicare, let's put everybody in one big exchange like the president would and buy them all a basic health plan based on their age and their income and have them subsidized. So we have one system that functions together, and we have essentially these community, whether they're for-profit or mutuals, well-regulated health plans buying everybody a basic health plan with a level of subsidy based on their age and income. He's a very liberal Democrat. He has the most market-oriented plan out there. Just to show how screwed up the politics are, a couple of Republicans said, this sounds good, I'll endorse it. Senator Bennett from Utah lost his re-election, a conservative in Utah, because he had the gall to come out for the most market-oriented thing that happened to be supported by a Democrat. And now Democrats go out and say, oh, we can't do that. It's a terrible idea because it looks too much like what some Republican might have suggested. The reality is when you get past the rhetoric, you're trying to change behavior in the health system. And the best plan out there is Ron Wyden's has been for a long time. It can't pass because all these institutions with gleaming new hospitals and buildings and bed towers have all been built up in all these communities with too much infrastructure that it's going to have to be, it got built up gradually over the last 60 years. It's going to have to be changed gradually over the next 60 years. It's not going to happen overnight.
I would say that illustrates the importance of thinking about, never think about policy without the politics.
Mm-hmm.
So, you know, I fell in love with the Wyden-Bennett plan. I got mushy about it, moist in the eyes every time I thought about it. And so I would go to the White House and talk about Wyden-Bennett. And I remember a hearing at the beginning of the ACA process. There were like 10 or 11 health economists in this one Senate hearing, and they were all for it, basically. And so then you'd go to the White House and you'd say, what about Wyden-Bennett? And they'd say, if we were designing our healthcare system from the ground up, we'd be for that too. But that's not the world we're in. We're not going to get rid of the employer deduction. So we're in a different world. And so the debate is always, you know, fighting with the army you got, in Rumsfeld's phrase. And so it's interesting to me now to talk about some of the reforms you talked about. I remember in the middle of the ACA fight, I went over to the OMB and was interviewing all these health economists about what would bend the cost curve. And they finally said, we don't know what'll work. We'll just throw some stuff out and we'll figure it out. And so now, a couple years later, you hear a different argument, which is, we don't know what will work, let's wait and see. We've thrown something out there, let's just wait. There's nothing we can do right now, let's wait 4 or 5 years, and then we'll have an argument on health care after we've got a little more knowledge. My reaction to that would be to distrust and verify. I'm a little dubious that any of these things will work simply because I think the fundamental incentives are still screwed up in the system. And therefore, it's interesting to watch the debate among the people who do want to do something now, which is essentially a debate between the people who want to cap and the people who want to reform. And the way I see it, I don't follow it as closely as you, it's Democrats tend to want to cap down the overall spending, and Republicans want to, or at least notionally, want to reform the fundamental incentives.
Dave, I'd just say that it's reform, if you say reform is only doing some kind of voucher with private plans, then yes, I think that there is that divide. But I wouldn't, I think we've already talked about some other reforms, including carrying forward the reforms. And I also say the wait and see view, I don't think it's fair to say let's not do anything right now. Let's keep pursuing the path of reform that is just starting off, which is why it's hard to credit the ACA for this slowdown, right? So,
But, why do you get into this debate about, unfortunately, this is like vouchers, people say vouchers. I mean, Jim McDermott he's a nice guy, the ranking Democrat in Ways and Means. You're gonna give my grandmother in Seattle a $10,000 voucher, make her go buy health care. That's not the way it works. It's the way the Federal Employee Health Benefits Plan works. It's the way the ACA works.
not actually,
With
though. It's not, Tom.
President, I'm saying that what people are talking about for reform Medicare with private plans, it works the same way that the ACA does with exchanges, and the same way it does the federal employee. You buy a basic plan, and you get a subsidy level based on your income level. And when you look at price capping, look, the major experiment we've had with capping prices in Medicare, I was all over. I was the White House guy in 1989. Physician payments were growing at 15% a year. We had a Democratic House, Democratic Senate. I worked for President Bush. We cut a deal with Rostenkowski and said, we're going to set a target, 3% over inflation, for inflation growth. So the target is 7% a year, roughly. And Professor Shao at Harvard designed the system. We'll set a relative value. We'll fix all the price for all the docs. We'll put a price cap on. This is what the Democrats wanted. We were desperate to control spending, and we said, all right, we'll go with it. And we put that price cap in. And what happened since 1989? It started in 1992. Every time it came up, we went over the price. The target was 7. We spent 11. And Congress came back to make a tough call to ratchet down automatically the price. They delayed it. So what happens this year? As of this year, at the end of the year, you have a 28% cut for doctors, which will never happen. This SGR fix. We have one giant experiment for now, whatever it is, 30 years, 28 years of putting in a price cap and a volume control and adjusting it the way the macroeconomists who like 5-year plans would do. I'm pulling his leg. It hasn't worked. It's led to a complete
Neither
meltdown of physician
macroeconomists
payment.
work.
I'm kidding.
But here's the rub. So I think in the current political climate, liking competition is very, very different than disliking government. And I think what happens in healthcare is that you need an architecture to make these markets function. Okay, so you need certain regulations. And I think the folks who are pushing very, very hard for premium support plans, which I actually think have a lot of, not premium support, but probably like Medicare Advantage on steroids, I think has a lot of merit. The challenge is you can't put the infrastructure around it right now that would allow those markets to function effectively. So you probably can't, look at the exchanges, defining minimum standards, and just how aggressive that debate got. So it's not that people are pushing for competition, they're just essentially rallying against government. And I think it's important to sort of say
I'm
this.
for highly regulated competitive structure. So I'm
And
not
I
against
just
regulation.
don't think you can get that right now.
Sarah, let me just make one very small point. So when I say vouchers, first of all, because I think people understand what the term means, even if it has become pejorative, I think of it in the same way that, it's been used as a term in a whole series of debates, right, which is an alternative way of delivering public services.
Do you think it's a fair way to describe the exchanges as well, or?
Yes,
Okay.
I do, except for I will say that there is a small technical distinction between what the proposals that sometimes go under the term premium support and those that you might call vouchers. And I do think this is something it's so technical it gets lost, but it's really important to understand. The fundamental question, so get past, I don't believe there is evidence that the private plans I know there's evidence that private plans have cost more, and I don't think there's very good evidence that we can make it so that the private plans are going to be more effective than Medicare in controlling costs if we use Medicare's bargaining power effectively. But put that aside. The issue with premium support when it was originally designed, the idea was that the amount that was paid would be fixed, like the FE, Federal Employees Health Benefit Program, as a share of premiums, right? And so if you could get premium costs to stop rising, you save money. If not, you're paying 80% or 70% of whatever the premiums end up being. The shift that happened, and it makes sense that it happened because you want to get the Congressional Budget Office to score that you're going to get big savings, is we will say that we're going to pay this amount, which will, and we'll be vague about how it is, but it will only grow more than a certain amount. If the cost of health care, if health insurance grows faster than that amount, unless you have some kind of protections which would then vitiate the savings, you're going to be shifting more and more costs on the seniors. That's just a fundamental point. And that, I think, is often missed in the debate about this. And there is a distinction there. I think it may be a great risk or a great reward of the Obama approach, which is that it is actually, it at least aspires to pay some fixed amount of the total. But yeah, no, so if you do not have an effective way of controlling costs, and you say the liability of, say, the federal government only grow at this amount, you will essentially be saying more and more of those costs will be shifted onto seniors. The first version of the Ryan plan, it was going to be massive. Second version, it's smaller, and we should be debating that. My view is that if you think you can actually control costs through Medicare, as I do, that's the army we have and the army I like, then we should actually be, why would we want to go down the route of creating a lot of risk of shifting costs, particularly onto vulnerable beneficiaries? Yeah, go ahead.
I just have a comprehensive political point, which is my observation covering politicians is none of this is going to happen. I mean, at first I don't call them vouchers, I call them Pell Grants for healthcare.
There you go. I was going to say, there's a Pell Grant, a voucher.
Yeah. But you know, if you just cover the politics that I think you made reference to it, this is not a 50-50 issue, this is an 80-20 issue. Just don't touch anything. And people have, you go to the town hall meetings and people have a certain set of misconceptions. Yeah. One is they paid in, they get out. And I paid for this, why shouldn't I get my money back? The second is just profound distrust that anything the government's going to do, which is why Obamacare is still fundamentally unpopular. The third, and this I saw in the Social Security reform debate when in the second Bush term of W. Bush, is the issue didn't break down liberal Democrat, it broke down educated, uneducated. And that's because a certain number of people with less education in a riskier economic situation did not want any change they thought would increase risk levels in how they lived their lives. And it didn't matter if they were super conservative and everything else. And so when they talked about privatizing Social Security or whatever you wanted to call it, they were against that even if they were really conservative, because they have enough risk in their lives. And so these are all comprehensive reasons why nothing's going to happen.
Well,
and then
yeah.
the final one thing I just want to mention, you mentioned Danny Rostenkowski. I'm really struck by how every member of Congress I know has a certain image seared onto their brain. And I would go on YouTube and type in Danny Rostenkowski town meeting. And you'll get this news report, Danny Rostenkowski goes home to Chicago. I forget what the exact issue was.
Catastrophic health. The
Catastrophic.
first drug benefit. I was
Catastrophic.
in the middle of that one.
The
so.
only modern social policy to be repealed before it actually took effect.
Over my prone body.
Republicans have been trying to create a second version, but they haven't succeeded.
So you go, just quickly, he goes to this town hall meeting. They're angry seniors. They won't let him in the meeting. He's running away from them. They're chasing them with the walkers. And then he gets in his car and they surround the car. And it's complete humiliation.
So maybe you can't outrun the seniors?
Well, Rostenkowski was
And we don't have a car outside.
On the other hand, Rostenkowski was one of the greatest deal cutters ever known, and he did a lot of great stuff, and people don't realize Social Security was saved largely by him and Senator Moynihan and a few other people. And the Social Security retirement age, which is now 66, not 65, was moved 25 years ago very quietly by him, and nobody notices. People talk about moving the retirement age of Medicare to 65. It's 66 for Medicare, and nobody seems to have noticed. It's happened one month at a time for 12 years for Social Security. And the point is that Rostenkowski did a lot of great stuff because he had guts, and the guts is something that's sadly lacking in both parties in Washington.
I want to follow up on that. So I know being in Washington, we always talk about we're spending too much on Medicare. I hear the phrase tipping point all the time in my reporting, but I can't get someone to tell me, what says we're at a Medicare tipping point? What says we're spending too much? Maybe I'll start with you since you raised the point. When does it get to a point where legislators say, we have to do something? Like, what do you see as a situation where, after they've seen this guy get trampled by seniors on his car, when do they say, okay, that's a good idea?
I don't think we're close to that. I mean, it's the squeeze is happening now. This is not a future problem. If you're working on child health issues, if you're working on education issues, if you look at sequestration, the squeeze is happening right now. And I'm sort of mystified, by the way, why the domestic discretionary constituencies don't get together and create a young versus old generational warfare up front. And I sort of wish that would happen. I don't think it's a slow, one thing it's always worth pointing out, this metaphor of boiling the frog, that's not actually true. Frogs jump out of the water. But it's nonetheless a useful metaphor. And so I think it's this gradual problem. And it's very hard to see an 80-20 issue being bucked by either party. The Republicans fascinate me because notionally they support the Ryan plan. Operationally, I'm not sure any of them really do, except for Paul Ryan and 4 other people.
The answer is never, by the way, sadly, because I can tell you in 1981, in January of 1981, I started working for a senator from Washington State named Slade Gorton, and I remember first week I was there, he walked out on the Senate floor and said, healthcare expenses are 6.5% of GDP. They're totally out of control. This can't be sustained forever. We have to do something about it. It's absolutely a disaster and disgrace, and we've got to fix it. Number one national priority, and that was 6.5% of GDP. It's now what, 18.5, 19? So people want to spend money in healthcare, and seniors are a very strong constituent group. But when you look at it, it's not just Medicare. Medicaid is a bigger mess than Medicare by a factor of 100. Nobody ever talks about it because Medicare is more politically sensitive. Medicaid is a fiscal disgrace. There's no management to it at all. No state has any idea what their match rates are. Complete mess. And the disability programs are 2.5 times what they were 10 years ago. Do you think there's 2.5 times as many disabled people as there were 10 years ago? No. There's just massive political pressure to put more people in disability in the rolls. And when you look at the budget deficit, you're collecting $2.6 trillion and spending $3.7. And this isn't going to get fixed because Congress will never have the guts to fix it. When it's going to get fixed is all of a sudden when interest rates go from 1.5% to 18%, where they were when I got out of college. And then you'll have a national meltdown, and all the stuff will have to be fixed in a crisis, which is what will happen, sadly, when you have a total disaster, and everybody's going to have to pull the plug on all these programs. But, you know, Medicare, Medicaid, disability, Social Security too, are what you're eating up the government, and you're right, that's the fundamental problem. And we're not paying for it.
Anyway, I'm going to open up to questions from the audience in a second, so if you have anything burning.
Can I?
Yep.
Can
Oh,
I
yeah, go
respond
ahead, I
really
want to,
quickly?
yeah.
Just
do
to
that.
say, I think healthcare costs, bound programs are eating up the federal government. Social Security is not. I mean, I think if you look, so Henry Aaron a few years back did these calculations. He's an economist at the Brookings Institution. I think they hold true if you take all the, you know, the CBO projections and you just factor out anything that's driven by healthcare costs. Our long-term budget picture does not look that bad. I think there are two things I just want to put on the table here. One is that if we really value Medicare a lot, then we're going to spend more money for it. And so there's a real issue of where we get revenues to fund the program. The original proposal that led to Wyden, I don't know if Wyden Bennett had this, but the original proposal that led to it came out of the Workers' Econ Manual and others, where they wanted to use a consumption tax, a VAT, to fund healthcare. I think there's actually real merit in that. So I put, you know, so not only do I support an enforceable budget in Medicare, I'm also publicly in favor of consumption taxes, which is why it's so wonderful that I'm a tenured professor and not a politician. The other thing I would just say is I think there's a little bit we're being a little too pessimistic here. After all, Medicare spending growth, I think I've said it before, it's growing at 0.4% per capita faster than our economy. I know that in the past there have been periods in which cost slowdowns have been followed by rapid increases, but there is some evidence, I think, that we could do, and Medicare's costs have grown more slowly over time. And so I think, you know, we've spent vastly more than any other country on health care, but we do not, our citizens do not show vastly better health outcomes. We do not visit the doctor more often. We do not see evidence in these numbers that we're spending more days in the hospital. There is certainly more intensity in American health care, but there is a lot of evidence that we could save money. Let me just give you like two simple examples, right, that are pretty obvious. The way that we buy, you know, medical devices is completely broken, and we could spend vastly less if we did much more competitive bidding for medical devices. Two, drug costs have fallen in part because of the increased use of generics. There are ways in which we could accelerate the slowdown in drug costs that I think would be quite effective. It is notable that Medicare does not have the tools to control drug costs that Medicare or the VA do. And here again, you could slow the rate of increase quite substantially. So I guess I'm ultimately think if we value Medicare as I think we should, that we can afford it if we make a much more serious effort to control costs, and if we identify revenues, because over time we are going to have more people in the program. So even if we control per capita costs, we're going to have to figure out ways to finance it.
I mean, can I just ask Tom, you know, if we had, so big ball is sort of the Ryan Wyden, you know, dream changes that are structural. What are some small ball things that you would do tomorrow?
You know, look, a lot of things are changing. Things change slowly in healthcare. I've been doing this for a long time, sadly, and, you know, nothing changes quickly. But look, when I got to CMS, we had 3% of people with Medicare Advantage, now 28.5%. I can tell you, I don't want to torture the details, but the reason Medicare Advantage plans were overpaid, their prices have been coming down. The main reason prices are dropping is relative, because they're getting paid less, and they're very good when they get squeezed at cutting costs. But when you look, you know, the move to ACOs, I say is better than a sharp stick in the eye. It's okay. It's like Medicare Advantage Light. It's better than nothing. Giving doctors risk. The more you can get the risk out of the trust funds and the government and into some third-party capitalist, well-regulated hands, the better your performance is going to be. And I credit the administration for doing that. ACOs is a marginal move in the right direction. More people in Medicare Advantage is a marginal move in the right direction. Post-acute bundling, which they're for, and acute bundling is a move in the right direction. All these things to move more bundled risk into a third-party payer are marginally good, and they're all helping a little bit. So I think, there are a lot of things to give them credit for moving in the right direction. The big picture change is really, in just fundamental difference of opinion. Do you want to control costs by having the government control costs, or do you want to regulate markets and try to fix some of these screwed up things we have in the market to basically create, a well-regulated market of competition to control costs? And I tend to go on the more well-regulated competitive side. But, there's a lot of things going on that are marginally getting better.
I mean, so say something like the biggest tax exclusion there is right now for employer-sponsored health insurance.
I've been a fan for a tax cap for 30, there's absolutely no reason for those of you to understand. I'm a partner in a private equity firm in New York. Every penny I pay and my kids for health care, for braces, for eyeglasses, for anything is, why not? We just pay it out of the pot. It's a tax expenditure. Why would I get taxed on that money? So I could spend $35,000 a year on health care and my firm pays for it. The right policy, which Senator Baucus was for and got pounded by the unions.
Yep.
He was a Democrat, and many Democrats are for, including Wyden, is to say, look, everybody's entitled to a Blue Cross standard option health care plan. If that's $12,000 a year, great. That's tax exempt. You can get that pre-tax. Any more than that, you're going to get taxed on it. It's totally the right policy. Bipartisan groups, Democrats and Republicans are for it. Who was against it? In my opinion, short-sighted. The unions killed it in the president's reform plan. The president's for it too, by the way, because unions tend to have negotiated over the years, whether you're the communications workers forever, for very plush benefits packages, and they were afraid that they'd get their health care benefits cut and wouldn't get it back in cash. Number one bipartisan RAND study every economist I've ever met. Number one thing you should do is cap the exclusion on taxes, limit it, take that money and put it back in the pot for other people. There's no debate about that. It's all politics.
Also a great way to kill your political career.
It is, but there are plenty of Democrats and Republicans who are out there for it. The problem is it play as a trade-off. And look, I understand the administration went through a great negotiation to get this bill done. I don't agree with it all, but they deserve great credit. It was a Democratic Party for 50 years. They got it done when nobody else could, and they played a lot of trade-offs, and one of them was they didn't want to make the unions mad. So it was called the Cadillac, the little teeny sliver of it that they had left in the bill was called the Cadillac tax. It should have been a lot bigger, and it should have been what funded a lot more of the program, and that's totally the right thing to do.
I want to see, are there any questions from the audience? Anyone want to put something to our panelists? Or
So I guess we got
we have
microphones. Yeah, microphones at
if
the
you want to,
the
on both
outside.
sides of the room.
And if
So-
we can make the questions, not
Yes,
not
if you
comments.
could introduce yourself and questions, right, instead of comments. Go ahead, sir.
Okay, Jacob. Hi, I'm Bill Sage. I'm visiting the law school from the University of Texas. So if you read the table of contents of the Affordable Care Act, it's got 10 titles, the first 2 about health insurance, the third about the delivery of healthcare services, but number 4 is about health, keeping us healthier, and if we don't do that, we're broke as surely as if we don't get healthcare delivery cheaper. You haven't said a word about health.
That's a and what are we going to do about that?
Yeah.
Is the question, right? Exactly. What are we going to say? Thank you, Bill. So.
I mean, and so part of it, Jody Sindlar is here, who's the sort of smoking guru. I mean, part of it is we talk about the revenue shortfalls. Why not introduce sin taxes? So I think it's $100 billion over 10 years if you raise the tax on tobacco, alcohol, and sugared beverages.
Make Mike Bloomberg president for a year.
Yeah, but he just banned them. We need the tax revenue.
I'd be for it.
I mean, I would say one thing that fits in with what David said up front is that a lot of the things we could do to improve health would not involve health insurance. As much as I believe strongly that the basic financial security offered by health insurance and the access to high-quality care provided by insurance is crucial, there are also a lot of other vital things that we could be doing to improve health that we need funds to do. So these two things are not separate. Within Medicare properly, I think that a lot of the incentives for excessive amounts of high-tech specialty care, I think, are, if not sometimes iatrogenic, that is reducing health, but are at the very least very low yield for spending kinds of interventions. And so I'm happy that the Affordable Care Act did some things on the preventive front, and I think we should be doing a lot more there. But I think a lot of the changes that are needed are also beyond the health health insurance system.
Yeah, I would add, one of the bigger commitments the Affordable Care Act made to improving health was this $10 billion public health and prevention fund, which has, if you're a Democrat, it's, a great investment. If some Republican senators have criticized it as a slush fund for jungle gyms, to which Democrats will say, we're fine with it being a slush fund for jungle gyms. We think that'll actually improve community health. One of the things, I did a long series on that program last year, and one of the things that struck me as a real challenge is those programs usually don't pay dividends for decades.
Yeah.
So it's kind of a challenge in Washington where you're trying to create some immediate savings, but you're trying to also invest in programs that won't pay off, within a CBO budget window. So there's this real tension between, these longer term investments in health, and you've already seen that now in Washington, that fund has been cut back twice. I think it's about $7 billion right now. So it's been a very easy target because it's, a much more long-term program.
That's kind of a silly debate if you think about it. The agency, CMS, spends $1 trillion a year on Medicare and Medicaid, and that's a $10 billion fund over 10 years. I mean, it's a joke. When I ran CMS, we had a demo budget to demonstrate these things of $80 million a year, $70 million of which is earmarked by Senator Harkin and another senator. You couldn't do anything. So there's nothing. This little demo fund to try new ideas is harmless, and for Republicans to argue about, it's silly. The issue is much, much bigger policy. The real issue, which you look at it, and as I said, I'm not a big critic of the ACA structurally. I'm a big critic of the spending. 62% of Americans are going to get subsidized health care. That's insane. 400% of poverty is $94,400 for a family of four, which is not a lot in New Haven, Connecticut. It's not a lot in Washington, D.C. It's a hell of a lot in Kansas and Nebraska. And when you get to the point where 400% of poverty, 62% of Americans are going to get subsidized health care, the wheels have come off. And the structure is right. The amount of spending that is in this thing is absolutely, completely whacked out.
I think there's some interesting work looking at the relationship between how much we spend as a country and the outcomes we get, and inevitably you find that the countries that spend less get more. I think it's easy to sort of infer causation. I don't think it's there. The interesting part is the countries that spend very little on healthcare spend a whole lot more on the welfare state and the sort of ancillary services around it, so help for the poor, housing, early childhood education. And so I think it's getting over this fallacy that healthcare or healthcare spending is exclusively the driver of health, and I don't know. There's something. Sitting here, it's sort of.
One of the great things about being in CMS administration, you tried for a few years, you get to go to every crappy town in America and see their hospitals. I can tell you, you go any place in the Midwest, and I've been in virtually every county and every state at some point, and there's boarded up shopping centers and boarded up everything. I can't guarantee you they have a brand new hospital, a brand new wing that's supporting the economy. If you look at the economy of central, I don't want to pick on any state, Iowa, which I've been to a lot of, or Kansas or Nebraska, or pick any state, Medicare. I'm not saying it's wrong, but the economy is Social Security checks and Medicare through the hospital. And the rest of these towns, in many cases, I'm not saying it's good or bad,
Right.
but the fact is the social policy is wild.
But there's this element of tragedy here where we're all saying there's this huge problem, nothing's going to happen. First of all, we know
Welcome to my life.
Right. But there's got to be, so is it worth creating a Federal Reserve for healthcare? You're sitting here watching a train wreck. You just happen to be going very slowly as you approach the wall.
Well, on that, optimistic note, I want to switch over to our next microphone.
This is a small ball question for Professor Cooper. Mr. Scully has been through one of these cycles before where hospitals acquired independent physician practices, and it didn't work out very well. The past 10 years, we've given hospitals more money, site of service differentials, the various add-ons that come with teaching programs, so-called provider-based reimbursement, which they can use to now acquire physician practices once again. Past 10 years, round numbers, we have 100,000 more practitioners and 100,000 fewer independent practitioners. Does anybody care that we seem to be buying the same service at 2 or 3 times the price, and that is our official government price-fixing administered price policy? Is that something which we can possibly look at so that when the Medicare beneficiary goes to find a doctor, they won't be necessarily going into an institution?
So I think it's an incredible point. I think it's something that was raised in Simpson Bowles. Basically, chemotherapy is a great example. You get a different rate if you have it locally at a doctor's office versus going into a hospital and getting it. And right now what the hospitals have discovered is if you buy up the local clinics, you can get twice as much for the same thing. So I think pay parity is incredibly important. It's in Simpson Bowles. I think it's something they should do tomorrow.
I think the issue he's talking about, you and I may be the only ones in the weeds on this, but the problem is 7 years ago, 35% of physicians in the country were were working for hospitals. Now it's 60%. And part of this is just the consolidation fear. Most docs are selling their practice to hospitals. Part of the other thing, though, is if you were a doc across the street from Yale Hospital and you had an independent practice and you got paid $100 to see a patient, the second you sell the hospital, Yale Hospital, you get paid 130% because your hospital-based, your reimbursement goes up. Same patient, same thing, just change the sign on the door, and that's why a lot of these docs are selling. And it's driving crazy behavior. We happen to own half the hospitals in Albuquerque, so I'm just, this against my interest. But when you look at it, when the hospitals own everything, and I love hospitals, I used to run a big hospital association, what do? They don't keep people out of hospitals, they fill them up. When the docs work for a hospital, the incentive is to fill the beds, not empty them. So independent docs are a much better thing, and the policy, I think, unintentionally and innocently has driven docs to sell their practices to hospitals. This massive consolidation in the last 5 years, 6 years, it's incredibly unhealthy for the healthcare system, very dangerous, and you're totally right. I don't think people are talking about it enough.
Yeah. You have a question over there?
Hi, yeah, I wanted to pick up on the health issue again. We've had this conversation sort of as though everybody's health status is exogenous, but we know that a lot of the costs associated with Medicare have to do with chronic conditions that people can, to a certain extent, prevent by lifestyle choices. And there's reason to think that there's aspects of benefit design that could actually affect those choices. So sometimes I wonder if there's sort of a disconnect when people spend most of their life, having employee insurance and having a certain carrier, then they retire, switch carriers, and Medicare sort of inherits the problems of old age that the prior carrier didn't really have any incentive to prevent that much. So sometimes I wonder, could we reduce Medicare costs by preventing more illness if we had more of sort of a situation where everybody was in the non-group market and we had a more sort of privatized version of Medicare and people could retain the same carrier from their earlier working years through their older years?
I agree. I mean, you see United Healthcare, which is a large share of the Advantage program. Why could we figure out a loop around so that they could essentially capture somebody from before? The challenge there is what happens if they start skimping on quality. So essentially what you think about is the analog to cell phones. I can buy a 3-year plan that's a whole lot cheaper than buying minutes each time I need to use it. The question is what happens if the quality of the service goes down? And so I don't know, we've gotten the contract, what happens when you lengthen the contract and how you maintain quality during that period? But I think it's absolutely right.
I think we should get some more questions.
My name is Billy Liserson. I'm a research scientist. I work on fruit flies, which makes me the doctor in the family. My mother passed away at 87 last year, and she was on Medicare. One of the things that has struck me about your discussion, it's very wonky, but when you think about healthcare and about the actual effects on people and what they're choosing, I wonder if you're not missing the forest for the trees. And the reason I say that is when you're sick, whether you're old or young, you're not making, there are emotional issues. You may be demented, as my mother was, unable to make really sensible, rational choices in a marketplace. So on that score, I kind of think that you have to be careful about how you structure things, thinking that people are going to go out and understand what care is best for them. My mother thought the doctors knew what was best for her. She relied on them. If they said to go do this or go do that, I was representative for her. The other thing I would say that I am a little skeptical, my mother grew up in a generation that believed that doctors were there to take care of people. And all the discussion now is markets and money and setting it up so the right incentives are there so that we can pay people to be doing this. And I think that that's a fundamental change in the social contract, that by saying what we should be doing is having money be the rule rather than having people taking care of other people, that causes a big problem.
Thank
And
you. Do you want to kind of take on the more human element of Medicare reform?
Well, I'll just say, look, realistically, I totally understand what you're saying, but the reality is, it's just a fact of life. I think the healthcare profession's filled with the most honorable, wonderful people I know, and I've been doing it for 35 years. It's the money drives behavior. So when you look at, my mom was in the hospital when I was running CMS for 5.5 months with osteomyelitis, went through 6 hospitals. Because of the way the fee-for-service system worked, no doc, her brother was the chief of staff of the hospital. Docs came through because they get paid for seeing the patient. Every specialist in Philadelphia came through and checked the box, saw her, Nobody was responsible for her care. They weren't bad guys. They're trying to do the right thing, but they're all being squeezed by various payment systems, and the anesthesiologist and the surgeon and every other guy comes by, and it's drive-through medicine. They're all trying to do the right thing, but they follow the incentives that the system creates. Hospitals are wonderful places. They follow the incentives the system creates. So I think if you're trying to be great over here for your mom or my mom or anybody else, you want a system that creates the right incentives for these people who are really trying to do the right thing, to follow the flow. And I happen to believe that when somebody's at risk for taking care of your mom for a year or 3 years or whatever, and they're looking at the whole package, they're going to worry more about preventative care and the whole system because their money's at risk. And there's nothing unhealthy about that. It's just the way the system works. The problem right now is nobody's responsible for anything. Everybody comes through, every doc, every hospital checks the box, maximize the reimbursement, and they're not trying to be evil or bad. It's just the way the system's set up. And as a result of that, no one's responsible.
Well, I would just add to that I think one does not have to have a kind of mutually exclusive view where the incentives matter, but professionalism and norms, professional norms or expertise don't matter, because the idea that I think here Tom and I agree that if you you want to set up the incentives properly, allow physicians to have clinical autonomy in the right ways and the right kinds of support systems to allow them to deliver care effectively in ways that are integrated across different providers and so on. And I would only just say here that I think there are two kind of sleeper issues here that matter a lot for healthcare costs. That have kind of gotten off the radar screen. One is liability and malpractice. I think this is it's a mistake the way it's broken down on purely partisan lines, because the system just doesn't work very well, and it is shaping the way in which doctors interact with patients, and it's shaping, I don't think it has a huge effect on overall health costs, but I think it does shape the way the system plays out. The other is there's a lot of conflicts of interest in our system with physicians and other providers. This self-referral to medical equipment, the fact that there's just rampant forms of kind of pharmaceutical marketing that take place. I just think that again, people will respond to those incentives, right? And if we really want people to prescribe like low-cost generic drugs, then it's probably not the greatest thing that every medical school, if you talk to those people, everything gets paid for in continuing medical education. A ton of this stuff is getting paid for by private companies who want to get people to prescribe expensive stuff. So I think we should have that kind of larger dialogue.
Just one other quick issue. As you were speaking, I was reminded of a piece Daniel Callahan and Shep Newland wrote, I think in the Republic, on end-of-life issues. And their point, I hear very varied things. I don't know the answer to this, how big a cost factor end-of-life issues actually are in this problem. You hear diverse things on that. But their main point was that our inability to think about the finitude of life makes us take heroic measures. And I would say from my experience when I wrote up their article, the feedback I got was it's rarely the person who's sick who wants to take the most heroic and expensive measures. It's the family at the end who wants to do those things. And the other thing I got a lot of feedback was, but if you give that family skin in the game and make them pay the costs, that suddenly they don't want to take the heroic measures. So I guess we love mom and dad, but $5,000. But I do think those end-of-life issues are a moral more that play into the incentives.
Yeah, over here.
How you doing? I'm Andy Carano, a retired psychologist. Once I retired about a year ago, I spent more time in doctors than all of my 35 years working. So in 5 years, I'll have Medicare, and you're frankly scaring me. But, a great question, by the way, and a great question by the other folks. I don't want to pile on here, but, David, I heard you speak a while back here, and I think you made a mention of Jeffrey Canada in New York, and you made the point that there's no cause and effect relationship between one variable and another, and that you got to throw everything at it. What else are we not looking at? Are we not looking at the elderly's behavior? You made a comment about people living down in Naples playing golf. Well, I know a lot of teachers that moved down there. They sold their houses, they worked hard, they went down there to be healthy. Because heat cures and golf keeps them healthy. So it's not just rich people living down there, it's people that want to stay healthy. Do we know anything about elderly behavior? I see people who refuse operations and get better. They make good decisions. They're not raping the system as much, but do we have any solid evidence that, people are doing good things and making good decisions? Do we have anything on that?
Could I just do a quick thing on just a general principle of how to deal with really complicated terrible issues like this one or like education. So there's a guy in the University of Virginia named Turkheimer who studies the relationship between poverty and IQ. And he finds that people who raised in poverty have lower IQs because of economic stress, bad nutrition, a whole bunch of reasons. And then he tried to figure out which variable contributes to the lower IQ, and he did a whole, decades of studies trying to figure out which variable explains the lower IQ. And he found that he couldn't. It's not any one variable, it's the intermarriage of a zillion different variables. And so how do you deal with a problem like that? He calls it the gloomy prospect. You can't see down into that problem. It's too complicated. And so to me, when you have a gloomy prospect sort of problem, which is healthcare, rising costs are a gloomy prospect sort of problem, you flood the zone, you try everything all at once, and hope that you'll somehow mysteriously generate a positive feedback loop to counteract the negative feedback loop. And so the Harlem Children's Zone, which Jeffrey Canada runs in New York, is an example of that. We don't know what causes poverty or what causes kids to drop out of school, so we'll try everything all at once within a geographic area and hope something works or you get a feedback mechanism. And that seems to me a sensible way to think about complex problems.
Yeah, over here.
In this case, there's going to be an inappropriate question, but the topic of liability came up.
Yep.
And when you ask physicians about healthcare costs, is often one of the main points that kind of comes up and is very aggressively discussed. Just a question about the policy and the politics of liability, possible arbitration, medical expert panels.
I mean, I guess I'd start by saying, within the economic literature, they found basically no effect of malpractice on rising healthcare spending. I mean, it doesn't mean it doesn't exist, but there's not been any evidence that's shown it.
I'll send you 100 studies.
No, I mean, so I think it's important, but I don't think we know definitively that that's.
Well, look at California. I mean,
I think Zach is accurately summarizing the economics literature
Uh,
in this,
so-
which
so now-
is shown small to non-existent effects.
Right.
That
Now,
is-
the flip side is, what do you
but-
do? So I think
I'll-
safe harbors are a really good idea. So if you follow clinical guidelines, you don't get sued. And so I think changes like that matter, but I think it's easy to overstate the importance.
the most liberal
medical
state in the
liability.
country, arguably, is California. The tightest malpractice
Massachusetts
laws in
would
the,
argue
well,
with
all
it.
right, tie. Certainly close is California, certainly the largest state. They've had significant malpractice reforms and caps in California since 1972. Has not caused any great economic damage. Their costs in California have grown much lower generally than the rest of the country. Now, you can argue they slow at a lower base, but if you ask docs in California, they think it's a much better system. So the argument's political. It's never going to happen. I've been fighting this fight for 35 years, too.
But if you
And
ask
it's
docs
not just
anywhere,
Democrats,
they'd say
by
it's
the
a
way.
good
There are a
idea.
bunch of senators that are Republicans that are old trial lawyers. Physicians and hospitals don't care about this that much. They care about it, but it's one of 25 other issues. So I don't know what your specialty is, but I guarantee if you go to the College of Anesthesiology or the gastroenterologist, they'll say, I care about malpractice reform after the other 14 reimbursement issues. Trial lawyers care about this and only this. They raise a lot of money. They give it to Democrats and Republicans. It's not a close call. It'll never happen. It's 100% politics. Trial lawyers are mean and tough, and they give a lot of money to politicians. It's a fact. It's a sad fact of life. But I mean, if you go to California and ask any doc in California, any HMO in California, anybody in California, Micro has kept costs down, and California should be the model for healthcare in this country. 'Cause
But I think
it's much
something
more
like simple,
efficient.
like safe harbor reforms, is something that very few people could disagree about.
I have no problem with any of it. For all malpractice reform, I'm just saying the reality is it's a pure, raw political issue. Trial lawyers make money on malpractice suits, and it ain't happening.
So
I want to try and fit in the two
Yeah, let's do that.
questions we left over here. So go ahead.
Hi, I'm Tim. I'm a grad student here at Yale, and I'm really interested in the politics of death panels and cost effectiveness analysis. And so I guess my understanding, and this might not be quite right, is that right now Medicare can't deny coverage for something purely on the basis of cost. If it's an expensive drug or expensive procedure, as long as it's shown to be clinically effective in some way, you can't deny coverage for it. So I guess my question is, A, do you think that's one of these things that's going to have to change down the road as we talk about these very scary numbers? And B, or B, are the politics just too blood-curdling for that to happen?
Well, let me speak to that really quickly, and Zach may have a somewhat different perspective since he's very close to what's happened in the UK with NICE, which is the National Institute for...
Throwing me under the death panel bus here.
Yeah,
I see it coming down
and
the
he also
track.
told me
Commissioner
personally that
Seena's
he loves
Got
death
Berwick
panels.
right here
and
in this panel.
I'm just trying to create a diversion for David Brooks. So let's just remember what the death panel debate was about. It wasn't about cost effectiveness research initially. Actually, it was about a provision that said that you could that would support counseling about end of life care. So, and then it moved over to comparative effectiveness research, and they found Zeke Emanuel, who, besides being Rahm Emanuel's brother, seems like a pretty mild-mannered guy, but turned into like Dr. Death. Medicare has a statutory restriction from considering costs, and it's worth noting that the IPAB has an additional restriction on it, which is it can't change or reduce benefits while trying to control costs. So we're not anywhere near that. My own view is that that there should be move in the direction of thinking about the cost effectiveness of interventions, but that there is a kind of tricky issue here, which is that first of all these decisions are usually treated as incremental. That is, we grandfather in everything we're doing today. I think that's a really big issue and worth thinking a bit about. So it might be more effective rather than turning some independent agency into like the arbiter of what Medicare should cover, whether it's cost effective or not, which is a really big step. Right now what Medicare does is kind of backdoor ways of doing this, where it's only for certain conditions or certain populations, which turns out to have the effect of reducing the cost of very costly treatment. And this is going to explode with personalized medicine. It's going to explode with some of the really high cost drugs on the market. But we also, I actually think that one way to think about this would be to actually retroactively think about differential cost sharing with protections for low-income and very ill patients, tiered based on the effectiveness of. So you could say, for example, that as we do with drugs, generic drugs, right, that you have a lower cost sharing requirement than if you go for some really fancy brand name drug, but actually have it informed by some knowledge about what the comparative quality of those is. So I could just see nightmarish scenarios. I mean, already we have a rule that stuff has to be approved. It's an FDA rule. There's no cost effectiveness, and Medicare then has to approve. And I'm sure Tom can tell us about how fraught that process is. But my own view is that it might be more useful to think a little bit about, okay, globally rather than incrementally with each new advance, what are the best ways that we could encourage people to use more cost-effective methods?
I think we have one question left in about 2 or 3 minutes, so why don't we get to this? And I think we should all be up here or afterwards if anyone wants to follow up on that. Go ahead.
Hi, my name's Romana. I'm actually a student in Professor Cooper's class. So I truly believe that we do need a structure in place to bring down the cost of healthcare because it's rising astronomically. But however, there is a concern of revenue loss due to premiums going up. We're going to be paying higher taxes and also an increased number of enrollees for Medicare and Medicaid. And then there's the problem of health exchanges because there's states that want to do it, there's other states that don't. Federally, we might have to get involved and then we have to pay costs there. So my question is, I'm really apprehensive and scared about the future of our country because we're already taking up 17% of the GDP. So congressionally, politically, we have this division between the Republicans and Democrats, and I think Thomas Scully said that there's really no substance to it, they just take sides. What can we do so in 3 or 4 years after January 2014, and a lot of this is implemented, our country isn't in a huge amount of debt and deficit? Because we're already at $11 trillion in debt. Or is there anything we can do?
It's not going to happen in 3 or 4 years. I can tell you, housing prices are cheap in Canada, if that helps you. The reality is, to me, I'm a moderate, despite the perception here. The reality is that there aren't many moderates left in Congress, sadly. And even the liberals, I was very friendly with Senator Kennedy, who I didn't agree with anything, but he was great to work with and easy to work with. He actually believed in doing stuff on a bipartisan basis. Medicare Part D never would have passed. He supported it when it was going through the Senate. It's the only reason it passed. So just getting back to the culture in Washington where people can work together. Now, if you're Republican, you work with Democrats, you're evil, and vice versa, which is sad. So, wherever you live, whether it's, supporting the Bob Corkers of the Republican Party, who's a moderate senator from Tennessee, or Mark Warner's in the Democratic Party, and supporting people like that and making it okay to work things out and find a middle ground again. Because, Democrats aren't going to get everything done, and neither Republicans. I mean, it's very rare to have one little week in time, whether you like the benefit or not, where President Obama could push through that bill when he had 60 votes in the Senate. That's never happened in my lifetime, probably won't happen again. You have divided government, and the only way to get stuff done is to have bipartisan people working together. And you've increasingly got a liberal Democratic Northeast and a conservative Republican South and Midwest, and it's like two different countries, and it's a sad thing. So I'd say the number one thing you can do is encourage moderates to be moderate and actually talk to each other, because otherwise I'm getting too old to worry about it, but you're stuck.
I would just quickly say, I think that is putting the cart before the horse. You can't create a culture of cooperation and then solve problems. You solve problems and then create a culture of cooperation. And so I'd say the thing that needs to be done is you have to change the debate. Right now we have a debate which is the traditional big government versus small government debate. It's vouchers versus state control. And we all know how that debate shapes out in issue after issue. It's a 50-50 debate. And so to me, you have to change the debate from big government versus small government to present versus future. And Medicare is present consumption. And so the emphasis should be what can we do to increase future investment and decrease present consumption? And then try to get a series of policies that confuse the two issues and break out of the orthodoxies. And that would be up to the administration to do that. Politically, I understand it's ruinous. As soon as they talk about Medicare reforms of any sort, they get this spider sense tingling. The Democratic base is going to go crazy. And the Republicans, as I say, are notionally in favor of these reforms. I really don't think they deep in their heart believe in them. But I do think it takes leadership to change the nature of the debate. Without that, we are stuck in the same old World War I.
Yeah, I would agree. I think it's small steps, combining the deductible that get people to agree and then move forward. The second is, I think, the big reforms, which I think you and I don't disagree about terribly. Big changes in Medicare, I think, are going to have to get passed by Democrats. I think they're the only ones who fundamentally have the public trust on the issue. And so I think at the end of the day, the ball's in their court. And so I think we do have a 4-year window with the Democrats and say, look, you trust us on it. It's a big issue. Let's move forward with it. Because I don't think the Republican brand can make this reform, can do it credibly, and can ever get the support to make it happen.
I agree with you on that.
Yeah, I would also just add, let's not end on too dark of a note here.
You just had a huge sucker from the student. I think you did pretty well.
This is actually Zach's student.
Oh, Zach's student.
So yeah, and I want to offer a couple of notes of reassurance. I mean, one is to say, I mean, we are talking about, again, some very serious challenges, but where there has been some movement forward. I mean, we were 5 years ago contemplating no action to help the uninsured, to try to do something effective to deal with healthcare costs, and we're moving in the right direction, broadly speaking. I agree with David. I think part of it is thinking about how can we have a discussion that is about the longer-term challenges we face, both economic and with economic policy and health policy. And it is true that sort of we've seen a falling away of kind of the moderate impulse. I think that, and I've thought about that a lot as a political scientist. It seems to me that the three most important things that we can do in that context is, I do think we need to make our political system ultimately more majoritarian. And this cuts against the grain of a lot of thinking, because it means that we have to accept that sometimes we're going to be on the losing end of majority fights, but having essentially a 60-vote threshold on every major issue, except for the budget in the Senate, is a very, very big hindrance to effectively addressing national problems. We need greater engagement of mobilized citizens on some of these issues, and this is going to happen a lot at the state level in the healthcare, so it's actually a chance to get involved. And finally, I go back to this view that I do think that for some of these fundamental decisions, they do have to be put on, if not autopilot, at least on glide paths that can be changed by politicians down the road. I have the same reservations that many of you do about the ability of Congress to micromanage every aspect of Medicare, say. Getting the large priorities right, creating institutions, both public and private, that have incentives to perform well over time is in healthcare, where the market alone is not going to do it, is what's essential.
Great. Well, on that more optimistic note,
Yeah.
I think we'll bring it to a close. I think our panelists deserve a round of applause for a very spirited debate. If you all have any lingering questions, we're here and happy to answer them, and thank you for coming.
Thank you very much.